In this audio lecture, I'm going to talk about the transplant reactions. So we already talked about hypersensitivity. Now we're going to talk about transplants and organ transplants. So the immune system limits transplants primarily through we already have an active immune system. And so if you put anything foreign, including a functional organ or a blood transfusion, we're going to see that the immune system really limits the success of this. And so it has to be as close of a match as possible. So we're going to improve success with as close of a match as possible. Now the various types of transplant reactions we have, the first type is allogenic. So allogenic is going to be a donation from the same species and generally is similar tissue type, right? So the match is going to be fairly close, but it might not be identical, right? Syngenic is talking about transplants coming from an identical twin. Autologous is coming from a self component. So auto means self, okay, and it is talking about stem cells generally. So autologous stem cell transplants would be generally what is this is referring to. And xenogenic is talking about another species. Okay. So this can be based entirely on the timing that these rejections actually occur, right? So the hyperacute tissue rejection occurs immediately to up to 3 days, right? And this is going to limit the success of the transplant. So because the individual has antibodies, and so these antibodies would activate the complement system. So we see activation of the complement system results in inflammation, cell lysis, clearance of the antigen from the body, okay, and multiple other things. But the main reason for all this is to get rid of it. And so we start a systemic inflammatory reaction. So we activate the complement system, we start this inflammation, and really it starts to extend beyond just the organ. Now we have acute tissue rejection, and this is going to be a little bit longer of a time frame, 4 days to 3 months. It is treatable, right, by taking care of the inflammation and taking care specifically of the immune cell. So maybe depressing immune function during this time would be beneficial. Right, this is going to be mediated by T cells. And it starts to induce the inflammatory response. The last type that we have here is a chronic tissue rejection. This occurs 4 months up to years. And so we see that this is an antibody-mediated response, and really it's antibody-antigen complexes. Right? So the antigen-antibody complexes end up getting inserted into the tissue itself, right? So maybe the donor tissue gets embedded with these antigen-antibody complexes, causing this vasoconstriction locally, okay? And reducing blood flow to that site, right? So eventually the organ ends up becoming necrotic because it's not receiving enough oxygen. So depending on the transplant, whether what kind of transplant you're getting is going to dictate the type of rejection that actually occurs. So if the host, because you could have 2 types of rejection, right, depending on the type of transplant, right? So if it's like a kidney, now the host immune system is going to be active, okay, and it's going to be targeting the graft, right, or the donor. Okay, so the problem with the host versus graft rejections is that the host immune system is seeing this thing as foreign, it's targeting it for destruction. Now, on the other hand, if you have a graft versus host rejection, this implies that the donors, the graft in this case, the donor's immune system is being active and it's attacking the host or the recipient of the donation's cells, right? So things like this would be like bone marrow transplants, where you have this bone marrow that is designed to be in another individual, okay? And it's going to be producing cells that have this immune system, okay, that have this natural immune system. And so they're going to be, if you donate a bone marrow it's going to be producing cells that target all the cells in the recipient's body as foreign, right? So then, in the host versus graft rejection, you see that the individual is going to be donating the transplant, and then the graft versus host, the graft is going to be targeting the host cells, right? So those are the two types of graft rejections that we really see. And really, we only see the graft versus host rejection if it's a bone marrow transplant. So the main way to treat these and to prevent rejection is to identify key signs of the rejection, like inflammation, right? So you're picking up on these key signs of this process. You need to be aware of normal organ function. So the textbook gives an example about kidney transplants. Well, when you give a kidney transplant, if you see any change in renal function, maybe urine production or filtration, like that would be abnormal function, right? So if we start finding that there are immunoglobulins in the kidneys, or there is glucose in the kidney, or if there's protein in the kidney, or bilirubin, anything like that would indicate abnormal function. Or if you decrease your urine output. Right? So we would complete lab tests to officially diagnose this, and one thing is we'd be looking at blood count. So you would expect the immune system to be activated at this time. White blood cell count would likely be increased. You would be looking for inflammatory markers. Maybe we're looking for liver inflammatory markers. So C-reactive protein is an inflammatory marker produced by the liver, right? If this is present in the blood, this means that there's an inflammatory response going on. So, and the last diagnosis that we would use is really organ-specific tests. So, looking at urine production, right? So, in the kidneys, where we could see other markers. Maybe we see abnormal proteins, right? So, which if we got a liver transplant, we might see abnormal proteins in circulation. And then the most effective treatment here would be ensuring a correct match. But if you do have a mismatch for some extent, we could see that the immune suppression is necessary, right? So preventing the body from responding to this like it's a foreign invader, because it's always going to have some kind of abnormal appearance and foreign presence, right? So we're always going to have some sort of immune suppression trying to prevent a rejection if at all possible, because we could get rejection occurring much later, like we saw with chronic rejection reactions. So that is it for transplant reactions. It wasn't that long. All right, until next time.